Hi, and welcome to Placebo, the podcast where my brother and I take turns teaching each other something about healthcare or medicine. I'm Kaylin Richards, and this is my brother.
And I'm Logan Richards.
How are you today, brother?
Wonderful.
Great. Are you ready for me to reveal today's topic?
Yes.
Okay.
I've been sitting on the edge of my seat since last episode.
Wow. Okay. So it is adding to an episode that you did previously.
Okay.
So we're going to be talking a little bit about chronic pain.
Ooh.
You talked about pain in general.
I know about chronic pain.
Okay. Well, we'll see if you know everything I'm going to tell you already.
We'll see.
Okay. We're going to start by talking a little bit about chronic pain and actually phantom pain.
Ooh.
And then we're going to go into some treatments for both of those because they're related.
Okay. That sounds great.
So in your episode, What is Pain? We talked a little bit about chronic pain, just kind of to give a definition of it.
Right.
Do you remember what the definition is?
Pain that has lasted more than 6 weeks, I think. I always forget if it's 6 weeks or 6 months, but I'm going to say 6 weeks.
They said they said 3 to 6 months.
Oh, okay.
Or the expected time frame for the healing of an injury. So if it's a minor injury or more massive injury, whatever.
That's a better way to say it.
So that is the definition for chronic pain. And I also want to talk about a specific type of chronic pain, which is complex regional pain syndrome.
Okay.
Okay. Have you heard about that?
Yes.
What have you heard about it?
Complex regional pain syndrome. It has to do with central sensitization, from what I know. So it's basically where I think it's usually preceded or can be preceded by a minor injury, like for example, an ankle sprain.
Could be, or it could be more major, like a fracture, but or it could be even more minor though, like a bruise or a cut or something.
And then it kind of evolves into what they call allodynia. So like you have a perception of pain with just by touch.
So like a feather brushes your skin and that's painful.
And super painful, yeah.
Mm-hmm. So there are other symptoms too. There's the intense pain that we talked about. There's like swelling or edema, like in the arm, say, that you have the pain in.
Yeah, the skin. I've seen pictures where the skin looks really red and irritated.
The skin, there's skin changes. It can look red. It can look mottled, they said.
Oh, okay.
There's temperature changes where that limb or area will be like warmer than the rest of the body. And then you'll have excessive sweating in that area.
Okay.
So a lot of like physical changes that you can see. And there was a physical injury, but the pain and these symptoms are lasting longer than they should for the injury to heal.
Right.
Is the sign that it's complex regional pain syndrome. And it would be like in an arm, say, if you had broken your arm.
Right, yeah.
Okay. I also want to talk about one more type of pain, and then we're going to bring these all together.
Okay, great.
Okay. So phantom pain.
Yes, I've heard of that as well.
Okay. When does phantom pain occur?
After an amputation.
After an amputation. So you've had your arm amputated, and you are still feeling like the rest of the arm is there.
Right.
The part that is not anymore.
Right.
And it feels painful, like that arm is in a really uncomfortable position or is being smashed or burned or whatever.
Mm-hmm.
Okay, so that's really...
But you can't move it.
Because it's not actually there.
Right.
Right. So those are 3 different types of pain.
Wait, what are the 3?
Well, chronic pain in general, and then we talked about the specific of complex regional pain syndrome.
Okay.
And phantom pain.
Okay.
Okay. And I think the general thing to remember that kind of brings these together is that nociception and the perception of pain in the brain are not the same thing.
Right.
Right, and you talked about that quite a lot.
Pain does not equal tissue damage.
Right.
In all cases.
So in these cases, the nociception is the sensors in the arm that we've been talking about.
Right.
Versus the perception in the brain of how much pain or damage is actually going on. So the brain is going to respond to what it perceives, which is not necessarily reality. So it might be getting, input from the nociceptors, but it might be paying too much attention to those. And so what it's feeling, what it's telling you you're feeling is not the reality of there's a huge amount of tissue damage.
Right, yeah.
Right.
But you're still experiencing that pain.
Yes, that's correct. It's just not reflecting a reality of current damage.
Yeah.
Yeah. So I want to talk a little bit about the brain.
Okay.
Okay.
I've heard about the brain before.
Good. Have you heard about the homunculus?
Yes, of course.
Okay. If you haven't, listeners, you haven't heard about the homunculus and you're not driving or something, I think you should Google it because it's a weird kind of creepy picture.
It's very creepy
Yeah.
looking.
So it is meant to represent on the surface of the brain what areas of the brain focus on what areas of the body.
Okay.
So for sensory, it's really specific. For motor, it's a little bit of a different story, but we'll talk about sensory to start with. If you Google the homunculus picture, you can see that the foot, for example, is a really small area on the brain marked out.
Okay.
Because you don't typically need a lot of sensory information from your feet. As long as you know that, like, ow, I've stepped on something sharp, you don't need a lot of fine differentiation.
So the idea with the homunculus, if I'm remembering right, is that it's a representation of what a human would look like if the proportion of that body part was the same size as the proportion of space that it's given on in the brain itself. Yeah. Is that right?
So the foot is drawn very little.
Meaning that it has really little area of sensation, if we're talking about the sensory
Meaning that
one?
the brain doesn't give that much attention to the sensation coming from the foot.
Okay.
And then the hand, for example, is really huge because there's a ton of important sensory information that comes from the hand. We need a lot of fine sensory information to do all the more intricate things we do with our hand, to be more precise in our movements. So, and then like the hand is really huge, like the lips and the tongue and stuff are really huge. It just looks super creepy.
Right.
So there's been studies done with monkeys. So they will do testing to see, what area of the cortex is used for what part of the body.
Right.
And they'll map out that, okay, this is the area that the monkey is using for hand.
Okay.
Say.
Yeah.
And then they'll put like a mitt over the monkey's hand so it can't use it and it's there for an extended period of time.
Mm-hmm.
And then, I don't remember the length of time, but a while.
Right, okay.
And then they'll do, MRIs again and be testing to see how things are distributed in the cortex for the monkey. And that hand that was not usable will have kind of shifted. There'll be like no cortex available for that anymore.
Like the space that used to be represented by that hand in the brain has changed.
The things on either side will have like gone into it or something. Yeah.
Okay.
And so that's neuroplasticity. That's neuroplasticity in action. The brain will adjust to what you do.
Right.
Right. So another way to think of this is the brain becomes an expert at what it does a lot of.
Okay. Yeah.
Okay.
And the way that it changes is that sometimes if it's becoming an expert, that area can get bigger or smaller, the area of the brain that controls that. So.
Right. I used to speak French pretty well when I took French classes.
Okay.
And now it's been many years and I kind of have forgotten the French. So it's not...
Your French area has gotten
smaller? My French
smaller?
area. So it doesn't really apply to this sensory motor areas, but...
No.
But it's the same idea.
Okay.
So another phrase I saw was like, use it or lose it. So
you're talking about those are the 10 principles of neuroplasticity.
Yeah.
Okay.
Now it's the opposite is also true. So don't use it and you lose it. Right? So use it or lose it is usually meant in a positive sort of way.
Yeah.
Like use those language skills or you'll lose them.
Right.
Right. But if you're using the pain pathways too much or focusing too much on pain, you make those pathways stronger and stronger and stronger.
Right.
And so it's hard for the brain to not focus on them.
Mm-hmm.
Like I said, the brain is really good at what it does a lot of, and it wants to continue doing pathways that have been working for it in the past. Right. What happens with the chronic pain or the phantom limb pain, the complex regional pain syndrome, is that the brain has an inaccurate representation of the actuality of the body.
Right.
Okay?
Yeah.
Its homunculus will be skewed so that the homunculus is already kind of skewed if you look at the actual...
Skewed from normal.
Skewed from how a person actually looks.
Yeah.
But not skewed to how the sensory information should be.
Right.
Right. So if you have chronic pain, the information is skewed. The brain is paying too much attention to the nociception information coming in from certain areas. So either they've like allocated too great an area in the sensory homunculus, or they're too sensitive to these inputs, or something like that.
Mm-hmm.
Okay. So in phantom limb pain, an interesting thing is that that limb is no longer there.
Right.
So what we would expect to happen, what happened in like the studies with the monkeys, where they had no use of a body part, even though it was still there,
Right.
that the brain area allocated to that is gradually subsumed by other functions that are still present. Okay. What happens in the case of the phantom limb pain is that's not happening. The brain is actually still believing that it's getting nociception, that it's getting pain input from sensory input from a limb that is not even there.
Right.
Yeah. And I'm going to talk about some treatments that are kind of cutting edge and proposed for chronic pain and phantom limb pain, but one that is specific to phantom limb pain is a myoelectric prosthesis.
Oh.
That's a kind of prosthesis that a person can move by thinking, just like you do with so you can open and close your hand by thinking, just like you normally do with your hand.
Right.
That's, originally part of your body.
Yeah. But it doesn't plug into your brain.
It doesn't plug into your brain. It connects to it has
connects to
sensors that are to nerves that are on the skin.
Right. So
at
you'd
the end of the residual limb.
you'd think about opening and closing your hand. That tells your brain to send a message through the nerves that would
have done that.
Would have done that
Yeah.
when you still had one. And those muscles then contract, and then the sensors can interpret that signal as you want it.
The muscles that are left there. Yeah.
Right, yeah, the residual muscles.
So people that had a myoelectric prosthesis did a lot better, have a much less likelihood of developing phantom pain, presumably because the brain is still able to feel like it's communicating successfully
Yeah.
with the limb that's
Okay.
not really there. That doesn't work for chronic pain, obviously.
No, because there hasn't been an amputation.
No. So we're going to get to more general treatment techniques now.
Okay.
And I was so excited because I was reading this article and I realized the author was the same author that you love.
Oh, is it V.S. Ramachandran?
No?
Lorimer Moseley?
Yes.
Yeah.
Although he did mention a study by
I thought
V.S. Ramachandran.
Yeah, I thought you were going to talk about the mirror box.
Well, there was some talk about that.
Lorimer Moseley is the best. He knows
He's the
everything
best.
about pain.
It was a great article. So he talked about kind of there are three different prongs that you could focus on treatment for chronic pain or complex regional pain syndrome or phantom limb pain.
Okay.
And so the first one is cognitive and behavioral strategies.
All right.
Okay. The second one is that you want to try and normalize the sensory representations in the homunculus.
Right.
And the third one is you want to normalize the motor representations in the homunculus.
Okay.
Okay, so we're going to talk about the cognitive and behavioral strategies first.
Okay, great.
For cognitive and behavioral strategies, okay, it's a little bit interesting. He at first talks a little bit about like Pavlovian and operant conditioning. Do you remember those things?
Yes.
Yeah, Pavlov's dogs.
I remember that.
Where they were doing a study where they would ring a bell and then feed the dogs, and then eventually they would notice that when they just rung the bell but didn't feed the dogs or have any food, the dogs are still salivating like they're ready to eat. Lorimer Moseley says this use of conditioning to help someone not feel as much pain can occur outside the awareness of the person.
Okay.
So as a care provider, I guess you could be doing this a little bit. So he talks about how people with this high level of chronic pain, for example, have a lot of pain behaviors and are incapacitated by the pain. Pain behaviors meaning they don't want to move because it hurts, for example. Okay.
Yes. They call that fear avoidance.
So you're incapacitated.
Okay.
Okay. So the goal of this treatment would be to decrease the pain behaviors and to increase healthy behaviors.
Sure. That makes sense.
So, and then reduce medication needs. And so what they wanted to do was change the responses of significant others, like friends, family, whatever that's around this person, from solicitous, which is like, oh, I'm sorry you're not feeling well.
Yeah.
That sort of thing. Like, what can I do to help you? That's someone's natural response, right? To a family member that's not feeling well.
Right.
But they found that's not helpful because from a conditioning perspective, the person displays a pain behavior. Their family member says, how can I help you? They get them what they need, whatever.
Right.
And so it is a learned behavior unconsciously. The person's not doing it on purpose, that the pain behavior is helping them get what they need.
Right.
So they said the family members should change their behavior to either distracting or ignoring when the person is talking about their pain.
Okay.
Or, bringing up things about their pain, which is interesting because that is what we're taught when working with patients that have chronic pain. And I didn't know the reasoning behind it was this conditioning thing, but you're taught to, when someone keeps talking about pain, to just say, oh, let's try and do this now. Let's try and do something else, and not to focus on it, because that helps people move on to a different, something different.
Right.
And if they can be successful at something, that I think is rewarding for them. And that's what this conditioning thing is coming back to.
Well, and if you're focusing on the pain, you're just reinforcing those
same
neural
pathways.
circuits that are confused.
Right. But it's hard because the brain likes to do what it's good at. It's like, this is a circuit that is well worn. It wants to keep running in it. So it is hard it's
hard to change.
Yeah, it's hard to change. But there have been a lot of studies focused on that have shown positive improvements in people's functional capacity, like what they're physically able to do, but also their levels of pain reported. So
okay,
interesting. It feels a little bit sketchy to be doing things technically without the person's agreement, is what he's saying, because they don't have knowledge of it.
Well, I guess what it means for the clinician is that
or the friend or family member of someone is.
Yeah, is that you can be aware that in cases of chronic pain, you can theoretically make it worse or reinforce it by the things that you say. Mm-hmm. And so if your goal is to reduce chronic pain, then you need to pay attention to what things you're focusing on with the words that you say and your actions.
And to get back to our main theme of our podcast, placebo, I think we talked about this even in our first episode.
Yeah, that's really placebo-y, isn't it?
Yeah, that if you say, oh, the person complains about pain, you say, yeah, I think this exercise is really going to help you feel better.
Yeah.
I know this has had a lot of positive effects in other people that with your same condition.
Right.
That you're kind of setting them up to expect that they're going to feel better, which they may from a operant conditioning perspective and from a placebo effect perspective.
Very interesting.
Yes.
So I did read an article recently that's called The Enduring Impact of What Clinicians Say to People with Low Back Pain.
Mm-hmm. Which is often chronic pain.
Right, yeah. And I remember one of the main takeaways was that if the emphasis by the healthcare provider was that you needed to protect your back, then that would often lead to increased symptoms and worse outcomes. But if the emphasis of the provider was that you needed to activate muscles around your back, you needed to move around, and then were given reassurance by the healthcare provider, led to better outcomes, including increased confidence by the person with back pain, a positive approach to trying to use exercise to treat the problem. Basically, what they found is in the title of the study that what you say will have an effect on someone's pain. Mm-hmm. And you're not going to be perfect, but you do want to keep in mind that the way that you explain things to people, the way that you talk about the symptoms that they're bringing up to you is going to have an impact on your treatment. And if you want to do a good treatment, then you're going to have to pay attention to those things. Mm-hmm. Yeah.
So I want to talk a little bit more in a related fork. No, not in a related way.
Area.
In a related area. I want to talk more in a related area about cognitive behavioral therapy.
Okay.
Which is used like in the field of psychology, right? To treat mental illness, anxiety, depression, things like that.
Sure.
But with chronic pain, the idea behind it is the same, is that you want to, part of a lot of people with chronic pain would feel helplessness. Like they've had this pain for a long time. Yeah. They don't know exactly why they have it.
They've usually seen a ton of doctors and PTs and healthcare providers, and no one has helped.
So it's really hard for people because they feel really helpless. They don't know what to do to solve the problem. Yeah. Right? They've tried a lot of medications probably. Things might have worked for a while and then stopped. So the goal of this cognitive behavioral therapy for chronic pain is to reduce the feelings of helplessness and being out of control, and then establish that you do have a sense of control over pain, and then to instate behaviors that will limit the impact of the pain over your quality of life.
Okay.
Things that this involves is like teaching people techniques to deal with episodes of pain, using like pain coping strategies such as diversion of attention, like the same as the other one, distraction. Like don't keep thinking about it. That is not helpful. I know it's hard to stop thinking about things when they want to kind of grab your attention.
Yeah. What about relaxation?
Imagery or guided relaxation that can increase your self-efficacy. Like you're feeling like I do have some control over this. and then cognitive reappraisal, which is like changing how you think about something. So instead of thinking, I've had pain for a long time, I'm going to have it forever, I'm never going to not have it, my life is going to be terrible, I'm going to die with pain and everything, I'm not going to be able to do anything that I want to ever again.
Yeah.
Saying like, I have pain now, I know that my body is not being damaged, I know that there are things that I can do to change how I perceive the pain, even though I still have pain now, I can work through it.
Right.
And I know I will not always have pain.
Yeah.
They also had like behavioral components like increasing activity level and doing like activity planning where you would sketch out how you would gradually increase your activity level to feel manageable.
Okay.
And this also included education about pain and the factors that control how you're feeling pain. So really, so people understand that they are not having tissue damage, because that's a big area of concern for people. Okay, so that's kind of we've kind of gone in a wide variety of areas there, but that's all focused in the cognitive and behavioral treatment techniques.
Okay.
Okay. Or cognitive behavioral for the last one. So the next section is the strategies to normalize the sensory representation, the sensory homunculus.
Okay.
Okay. So for this, we're talking about just to refresh, we're talking about the homunculus, where areas for the sensory, so like where the hand was really,
right,
where areas have been skewed because of the perception of pain over time.
Okay.
Okay.
And do they usually get bigger when people are in pain or smaller?
Depending on the area you're talking about. The area that is painful would get bigger because it would have more brain function devoted to it, and other areas would get smaller around it.
Okay.
Okay. So sometimes people will have pain in the foot, but then they might have actually like numbness in the ankle.
Okay.
And perhaps that's because the sensory area for that, like the ankle, has been decreased such that it's hard to tell what sensory information is coming from there.
Kind of taken over by the foot area. Mm-hmm. Okay.
So what they did to try and normalize these distributions is they would have people, they said stimulate a body part. So they would be touching, let's say it's your foot again. They would be touching your foot. Okay. Okay. Actually, let's not do the foot. Let's do the hand because it's easier with the example.
The hand. Okay.
Okay. So you've had a hand injury. You've developed chronic pain, complex regional pain syndrome, perhaps.
Okay.
Okay. So what they would do would be stimulating the hand, by which they mean touching the hand.
Okay.
Okay. And it helps with their studies if the type of touch, the type of contact that the hand was coming into was something functional. So they said, for example, playing a musical instrument, like touching the musical instrument, or unwrapping food or something like that was meaningful to the person.
Okay.
Okay. They also, and so just trying to do things with the body part that were functional. They also did studies where they were having the person discriminate between different stimuli in that area.
Okay.
So they did it either while they were touching with like different with objects, like they said, like a wine cork and a pen cap. I'm saying, what was that? Was that the wine cork or the pen cap going back and forth?
Yeah.
Or they did it with electrical stimulation and they were at different voltages. What was that? Was it the same as this or different?
Okay.
Okay. And they did kind of a lot of this. Like for the one with electrical voltages, they did 90-minute training sessions on 10 consecutive days. That's kind of intensive.
Yeah.
Yeah, that's kind of exhausting, I would think. They found that people's performance in like being able to identify the different stimuli improved, and then also that their tactile acuity improved.
Okay.
Improved, not approved.
So the goal of all these various different things that you've talked about, like the different types of touch, the different types of stimulation, is kind of to train that one area that has a problem, that our example is the hand, is to train that area, make you focus on it, and then by doing that, by doing the training, you make that area in your brain return to normal,
so
return
because
to
you're
typical.
So from what I understand, because you're focusing so hard on being really specific about what you're feeling in that area, it's kind of remapping itself.
Okay.
So that's what happened when they looked at the MRI scans again for these people. They found that they did previous scans. They had shown that the distribution was skewed, and then they did scans after the treatment, and they found that it had reverted back to the normal, typical distribution.
Okay.
So yes, that's what you're trying to do.
Interesting.
Yeah. As an example, they talked about trying to use this in a clinic with patients, not just in a study population.
Yeah.
So they did it with patients with the complex regional pain syndrome in an arm. And this was the one that had to differentiate between 2 stimuli of different widths at 5 locations on their affected limb, which was their arm.
Okay.
Okay, so they're just touching different places on the arm.
Yeah.
They did this twice daily for 10 consecutive days. And so this, you could teach a patient how to do it, and they could do it at home with a family member or something.
Right.
And they found that there was significant reductions in pain and disability. So the patients felt, or the people felt like they were more able to functionally use their arm.
Oh, okay.
Even with it really is pretty minimal compared to the first one with the study.
Yeah.
They did 90 minutes for 10 days in a row.
Yeah.
That doesn't take that long.
Yeah, I think you bring up an important point too with a lot of these where we're trying to induce like these neuroplastic changes, these changes in the brain. It does take a high amount of repetitions. Like you can't just do this 10 times and expect it to be better.
10 times once ever. Yeah, it's
yeah,
all
you're going to have
repetition.
to do it regularly and a lot.
Because the way that the
to
brain...
start to make the changes.
Right. I mean, if the brain changed every time you did one thing differently, it would be continually changing, right? It would be never be stable.
Yeah.
And it is continually changing to a minor extent. But yeah, so they did say that they found the most important thing was that you had to differentiate between stimuli. They did, as I talked about, they did start out just doing functional tasks, but they found that the most increase in ability to use the limb and then also decrease in pain was when you had to differentiate between 2 things, probably because you're focusing so carefully on what you're feeling.
That would be my guess.
And then, so the last part of Dr. Mosley's, and I should mention this article is written by him and someone else, but he is the primary author. His last section on strategies is those that are meant to normalize the motor representation, the motor homunculus.
Okay.
And so this is a little bit more fluid always than sensory. The neurons that move certain areas can change around a little bit more. They're not as fixed as they are for the sensory ones.
Yeah. Just as an example, so like I played soccer growing up and I was right-footed. Would you think, does it make sense with what we know about the motor homunculus that when I was playing soccer and using my right foot a lot to kick the ball and do certain motions with my right leg, that my leg and foot area in the motor cortex had a larger representation?
I think so, yeah.
Now, as I've stopped playing that, it's probably gone back down to more equal to like the other side.
Yeah,
okay.
That would make sense to me.
Okay.
So in this category, we're going to talk a little bit about mirror. We're going to talk a little bit about mirror therapy.
Okay, great.
Okay. Mirror therapy is used, well, I first heard it used to treat people who had had strokes.
Okay.
Okay, where you would, basically the idea is you sit upright. You have a mirror down like the center of your body, kind of.
Right.
And so you would
perpendicular to you.
Perpendicular to you. So if you have one arm that is paralyzed or very weak after a stroke, and you have your other arm that is typical, you would be, say your left arm is affected. You would be moving your right arm, but if you look in the mirror, it looks like your left arm is moving.
Right.
And that helps. They had found that helps the brain with neuroplasticity because the brain thinks that your left arm is moving, and it helps to kind of restructure it and get more motor return.
Right.
Okay. So they now have been trying to use the mirror therapy to help with chronic pain, particularly the complex regional pain syndrome.
Okay.
Okay. So that's where it affects like one arm, say. Okay. And it's been used, there's kind of a 3-step process that they use this with called graded motor imagery.
Okay.
Okay. The first step, it is sessions that last an hour long, and this is not with the mirror.
No.
It lasts an hour long, and you're looking at either flashcards or they have websites or apps where you can do this. And you look at, say your complex regional pain syndrome affects your arms. So you'd be looking at like arms and hands and stuff. Okay. And you're making judgments as to whether that's a left or a right arm or hand.
Oh.
And they're they're held in different positions all over the place.
We learned graded motor imagery starting with motor empathy.
What's that?
Basically, you take a video or pictures of someone that's not you, but doing a motion that you think might cause you pain. So if we have a hand example and...
Like opening up the hand all the way.
Yeah, opening up your hand all the way would cause you a ton of pain. The way that you would do motor empathy would be first you would do something that you think you might be able to do with just a little bit of pain. So maybe that's like, just relaxing the fist a little bit. And you'd watch a video or look at pictures of other people doing that.
Relaxing their fist or
relaxing
opening the whole hand?
Relaxing your fist a little bit. And you would then progress that as you got used to it, to where you could watch a video of someone opening up their hand all the way, something that you think might make you hurt. And then that's the first step, I guess, of graded motor imagery. It's called we learned it called motor empathy, where you watch other people do things that might make you hurt.
Okay. So, and then you go to the right and left limb judgments. So you're looking at pictures of other people's hands or arms in a variety of angles and variety of positions, and you say right or left. Is this a right hand or a left hand? Which involves kind of 3 stages, they said, in your brain.
Okay.
So you look at it.
That makes sense.
Okay.
First step.
And then you, in your like mind's eye kind of, you pretend, look at, or maybe you actually do move your arm into that position to double check.
So you try and figure out, because we're trying to figure out if it's left or right. So you look at the picture and then you, in your mind, might have to move that hand around a bit to try and figure out if it's a left or right.
Right.
Okay.
And then you make your determination.
All right.
Okay. And then if your determination is wrong, you might have to go back and look, pretend again, position your hand again.
Okay.
Okay. So, yeah, they have websites or apps that you can get that have these different limb positions that you can just go through and do on your own.
Yeah.
Okay, which makes sense because this is every day for an hour, so you don't want to be having to go to your
Yeah.
doctor, your physical therapist or whatever for this.
We should post the links to them.
Oh, I have the links right here.
Yeah. Lorimer Mosley and his friends, I guess, have they have a company down in Australia that produces a lot of these type of products to help people deal with chronic pain.
So the next stage is where you look at the flashcard again, and you purposely imagine putting your hand or arm into that position for each one. So you don't actually move. You try not to move for this.
Yeah.
For the first stage, you could if you want. You try not to move for this at all, and you just imagine going into that position.
Okay.
Okay, same thing for like an hour a day. And then the last one is the mirror therapy.
So you went through, that was the imaginary movement.
That was the imaginary movement.
Okay.
The last stage is the mirror therapy, where you are moving, you have your unaffected side, and your affected side is inside the mirror, behind the mirror. And so you move your affected side into those positions.
Right.
Right. Okay, and then you're moving and looking, it's looking like your affected arm is moving and you don't feel any pain.
Right.
Okay, so basically you are trying to reprogram your brain so that it can not do those automatic pathways to pain when you're moving your arm, for example, in the ways that it associates with pain.
Yeah.
Yeah.
So this is the mirror therapy. To me, it's almost like an optical illusion.
It is.
Like
yeah.
if you set it up right so that the mirror is aligned just right, and your view of the mirror is aligned just right, it really does look like your arm. And they said you really need to sell the illusion, though, to make it work. So, like, if you have a ring on the side that's behind the mirror, you have to take that off. Like, both hands have to look identical, so that, and then you have to really try and believe it.
Yeah.
In order for this to work
but it does
the best
work.
way.
It's very interesting.
But then it does work, which is weird.
Your brain is really, I mean, everyone knows all these little brain tricks that you can do where there's like a square with different surroundings and one of them looks bigger than the other, but really they're the same size.
Yeah.
Your brain is so trickable.
Yeah.
It's and so predictable that way, yeah.
And this is just a fancy way to help trick your brain into thinking that you have a perfectly fine, painless,
arm it's moving fine. Why would you think it's painful?
Fine.
Yeah.
Even though the one that is painful is behind the mirror, you kind of forget about it for a little while.
Because you don't see it. And
thus,
it feels like the other one is moving. Yeah,
kind of reduce the amount of time that your brain is thinking about that painful arm.
Mm-hmm. So it is very interesting. He kind of comes back around to V.S. Ramachandran here. And his idea with chronic pain is that the pain in the absence of ongoing tissue damage, so chronic pain, is caused because there's a mismatch between the movement and the proprioceptive feedback, the feedback that the brain is getting about the position and where the arm is.
Right.
So he thinks that this mirror therapy is going to kind of resolve that.
Uh-huh.
Because the arm's not moving, right? It's not getting painful feedback.
Right.
Anyways, interesting theories and a lot of interesting results to these studies. A lot of these have been really successful, these protocols, like to treat the complex regional pain syndrome.
Yeah, I think what's weird about all of these is that we often say that even though we don't know the exact mechanism that is happening, in the nervous system to treat them, the treatments are still working, at least, a large percentage of the time with the average amount of people. So we probably will never know, or at least not for a while, exactly, how pain processing works. We have a pretty good idea, but it's always changing. But
it's always more complicated.
Yeah.
Yeah.
But these treatments are still working. Mm-hmm. And so that's interesting. They've tapped into something.
We're talking about kind of future directions for research. There's always that, right? At the end of every research article.
Directions.
At the end of every research article. An interesting thing to bring up is that with chronic regional pain syndrome, people often perceive that their affected limb is like big, like enlarged, or bigger, bigger than it actually. I mean, it often might be swollen, but they perceive it as bigger even than it is.
Okay.
And if they view their limb through a magnifying glass, so it looks big, even bigger, then the pain is increased. And he thinks this is interesting, that maybe there are... he means that maybe because you're viewing it differently affects how your pain is, maybe using more higher level cognitive therapies can change the pain perception again.
Yeah.
It's an interesting topic. I hope that it might be of use to people to hear talked about a little bit more. I think that a lot of people with chronic pain a lot of people that I've worked with chronic pain feel misunderstood, or feel like people think that they're making the pain up, or...
Right. Well, I can imagine that having to travel from doctor to doctor, specialist to specialist, and then them never finding anything is...
Or feel really hopeless. They just feel like they're just going to keep taking higher and higher levels of pain medicine because there's nothing else that works, and they feel terrible in the pain medicine.
Yeah.
So I don't think these treatment techniques are that well known yet, because the vast majority of people that I see with chronic pain have certainly not had these things.
Well, they're certainly not publicly well known.
No. And I don't know if a lot of primary care doctors maybe know about them.
Well, yeah, you
might need to go to a pain specialist, and not everybody has that
opportunity or even gets the chance to be sent there, because someone who's seen them before thinks they're faking it, or has just told them the pain's all in their head.
Just seeking pain medicine or something, yeah.
So
I think in general these are successful techniques that are a little bit intensive while you're going through them, but what an amazing payoff.
Right.
And I think they would be amazing for more people to be able to experience positive results when dealing with chronic pain.
Yeah.
So we will have our resources as always on our website.
Right.
And I'll put up the link for the flashcards app and website.
Lorimer Moseley has a bunch of great products, and one of them is a book called Explain Pain, which I think I cited on the first pain one, and I will continue to recommend it. It's a really great book, both for someone who has chronic pain to learn about why they do, as well as clinicians that are helping people deal with it.
So you could visit our website at placebopodcast.com to look at our links and resources for this episode.
Right. And you could also look for the comment section to add a suggestion for any suggested topics, just like today's episode was.
Today's episode was suggested by AJ Koenig, so thank you very much, AJ. You could please give us a rating on iTunes. That would be so thoughtful and kind.
And if you like the show, share us with a friend or two. It would help us out.
Thank you to James Aiken for our music.
And we'll see you next week with a new topic.
Goodbye.
Bye.
He kind of comes back around to V.S. Ramachandran here, who you love.
Right. Well, I don't know if I love him. Jeez. I haven't even met the guy.